Hello, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia, and welcome back to now part 2 of highlights from Digestive Disease Week, Washington, D.C. 2024. I will refer you back to part 1, and I'll continue and pick up with some hot topics and exciting news. Let's get right to it. First is as it relates to 2 abstracts about oral health. My question is, perhaps as gastroenterologists, should we be better dentists? And I'll come back to that in a review that I'll do later in Medscape comments later this year, because there's a lot on this in the oral health status, and the oral microbiome is focus of the first 2 reviews that I wanted to highlight for you. One comes from a group in Portugal, and they looked at a collaborative arrangement with the inflammatory bowel disease physicians and the dentist. And in particular, they found that there was this high concordance as it relates to oral health status. The poor and periodontal disease, the prevalence was 55% in Crohn's disease and 70% in ulcerative colitis patients. Most of these patients with periodontal disease suffered from more severe stages of disease. They stage 3 and 4, more on the severe spectrum. Poor health status, evident due to the need of dental treatment, was evident in 88% of the patients overall, and 38% actually needed prosthetic rehabilitation. So again, they looked here also at microbiome, and there was an elevated abundance of firmicutes and Bacteroides in this population as well when compared to healthy control, and these are valuable indicators of dysbiosis. So again, something that oral health may have a significant role in our patients with inflammatory bowel disease. And then similar along the same lines comes from another longitudinal study here, single sectional, that was done assessing the oral and stool microenvironments of patients with active and inactive inflammatory bowel disease versus controls. This comes from Dr. Kezaverzian from Rush in Chicago. And they looked at salivary and stool biome, and also used a Mediterranean eating pattern questionnaire that was a validated instrument. And they found 36 of their patients underwent periodontal diseases using standard clinical evaluation and radiographs. And they found that there was a striking concordance between activity of disease and periodontal disease. There was genre changes in the saliva that were evident with Rothia and actinomyces, and they also had less divergent paths of the microbiome in the inflammatory bowel disease patients as well, what we've seen with other studies. But again, these are patients that had active disease, more severe periodontal disease. And what we're finding here in summary is that oral health really needs to be assessed in the patients with inflammatory bowel disease. There's lots of science around that about cytokine upregulation, in particular in periodontal disease. Things like interleukins get upregulated, TNF alpha makes good sense, but we need to be perhaps better dentists as we look at our IBD patients. So maybe a bidirectional as far as the involvements for IBD activity. 2 studies that talked about diet and inflammatory bowel. First is looking at guideline-based healthy diet. This is using large databases from the 2 Nurses Health study and also the health professional study, looking at a longitudinal assessment and adjusting here for patients that the participants were randomized to receive healthy diet and lifestyle intervention. And the effect was that there was a risk reduction for Crohn's disease over the period of time of about 13%, evident also on healthy lifestyle type things and avoidance of smoking. But it may be something that we start to talk with our Crohn's, in particular, those at risk, maybe that they could have some better benefit if they looked at a healthy diet, in particular in prevention of Crohn's disease. Along the same lines, in the ulcerative colitis population, there has been some concern about the development of chronic inflammatory disorders and autoimmune diseases with increased dairy consumption, and it really is little has been done in the inflammatory bowel area looking at this. So this is again using the Nurses Health studies and the health professional follow-up. They're looking at large databases. They found 347 Crohn's patients and 428 developed ulcerative colitis. There was no difference as far as dairy consumption as it relates to Crohn's disease, and there was an inverse relationship as it relates to ulcerative colitis. And it's over time, at least 8 years before the diagnosis, incremental dairy, in particular yogurt, seemed to have a risk reduction as it relates to ulcerative colitis. So something that may be of help in patients that may have some issues of concern about development. Diet makes a difference. Along inflammatory bowel disease, a study from Marla Dubinsky's group in Mount Sinai looking at the intestinal ultrasound response to biologic and small molecule therapy. Again, point of service use of endoscopic ultrasound in colitis has become very widespread in Europe, not very widespread in tertiary centers. Some centers of excellence are starting to incorporate this, but this was a prospective longitudinal cohort study that they did in pediatric patients and found a high concordance with the endoscopic mucosal healing and symptomatic, both of which were sensitivities and specificities in excess of 90%. It's a point of service, can be developed on a clinic day, takes about 15 to 20 minutes to do. It makes immediate adjustments potentially available to patients when we start to look at the interventions we do in inflammatory bowel disease clinics. I'll stop here and look forward to part 3 and talking with you shortly as it relates to the finales for Digestive Disease Week 2024. Dr. David Johnson, thanks for listening.